This 62-year-old male first noticed a resting tremor and loss of coordination in his right hand 8 years ago. He was eventually diagnosed with Parkinson's disease by a neurologist. He was started on levodopa and had a good response. 2 years later, the tremor spread to his left hand, and an increased dose of levodopa helped control the tremor for a few more years. The dopamine agonist pramipexole was eventually added because of wearing off, followed by the COMT inhibitor entacapone. He later developed dyskinesia, so amantadine was added. Entacapone was stopped since it can worsen dyskinesia. He then developed compulsive shopping, buying several items online. Pramipexole was reduced but could not be discontinued due to increased off time. He currently takes carbidopa-levodopa 25/100 milligrams, 2 pills, 5 times a day, 3 hours apart, pramipexole, and amantadine. His medications last 2 hours at most before wearing off. When he wears off, he has a tremor in all 4 extremities, a shuffling gait with occasional freezing, and extreme slowness of movement. In the on state, his tremors disappear and he can move more easily. However, he has bothersome dyskinesia. He wanted to explore DBS to increase his on time and decrease dyskinesia. Remember that candidates for DBS have motor fluctuations and/or dyskinesia that cause disability despite optimal medical management. This means they're on at least 4 doses of levodopa and have tried at least 1 dopamine agonist and 1 extending agent, as well as amantadine, if they have dyskinesia. This patient's levodopa is not lasting from dose to dose because it's taken 3 hours apart, but only lasts for 2 hours. He also has bothersome dyskinesia during on time. He's on a dopamine agonist and amantadine in addition to his levodopa, and he's tried the extending agent entacapone. Therefore, he meets the medication criteria for device-assisted or lesioning procedures. So he was referred for a multidisciplinary evaluation. Using the Movement Disorder Society-sponsored revision of the Unified Parkinson's Disease Rating Scale, or MDS-UPDRS, to measure his motor severity, he had a 50% improvement in symptoms when going from the off to the on state. Candidates must have at least a 30% improvement to qualify. Neuropsychological evaluation demonstrated minimal cognitive decline and no significant depression. Imaging did not show any contraindications to surgery. Because his goal was to improve on time and reduce dyskinesia, he was deemed a good candidate for bilateral DBS of either the subthalamic nucleus or globus pallidus internus. DBS of these targets improves all major motor symptoms of Parkinson's disease and dyskinesia. Continuous carbidopa-levodopa intestinal gel would be less likely to help his dyskinesia, as levodopa is the underlying cause of dyskinesia. Continuous subcutaneous apomorphine infusion is not appropriate given his impulse control issues. This is because apomorphine is a dopamine agonist which can cause impulse control disorders. MRI-guided focused ultrasound is better for unilateral symptoms.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.